Welcome to the OI Foundation podcast series. I am Petra Harvey, Director of Program Services here at the Osteogenesis Imperfecta Foundation. One of the primary activities of the Foundation is to provide timely, accurate, and medically verified information to medical professionals and constituents alike. Each OIF podcast episode features an expert speaker discussing various topics related to osteogenesis imperfecta. The OIF podcast series is a part of the ongoing educational efforts of the Brittle Bone Disorders Consortium, which is part of the National Institutes of Health Rare Disease Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium, or the BBDC, are led by the OI Foundation. Our podcast today will feature Dr. Jean-Marc Retrouvey, who will discuss craniofacial and dental issues in OI. Dr. Retrouvey is the Director of the Orthodontic Division at McGill University in Montreal, Quebec, Canada. He is also the lead of the Dental Observational Study through the BBDC. So we're so fortunate to have Dr. Retrouvey on the line with us today. Thank you so much for participating in this.
Thank you, Petra. I'm very delighted to be there, and it's a pleasure to participate in the OIF initiative. It's well appreciated.
Excellent. So we'll jump right in with the first question. What are the most common dental issues that you come across with individuals living with osteogenesis imperfecta?
Well, the first thing we should say most probably is OI, osteogenesis imperfecta, has many types and different severities. So as an example, the OI type 1 patients have usually less problems, and we go all the way to OI type 3 patients who present the most severe dental and craniofacial problems. The most common ones, which is the most reported, is Dentinogenesis Imperfecta, which is a problem that the dentin of the teeth, which is the foundation of the tooth, encounters. And what you have is, again, depending on the type of OI, you will have a different incidence. So some patients will have more DI, and some will have a lot less. You also have missing teeth. A lot of patients with OI represent some missing teeth. A lot of teeth will not erupt in the mouth, and they're called impacted teeth. They will remain in the bone for many years, and also are kind of difficult to place into the mouth, like we usually do on a non-affected patient, because OI presents some very specific bone issues, as you know. We also have malocclusions, which affect pretty much all our OI population. Again, different degrees, and it varies also by type. So we'll talk about that a bit later, I guess. And okay. Another issue we also have, and we discovered that in Orlando last summer, is a lot of OI treatment is geared towards our younger patient group, but a lot of adult patients report significant dental issues, one being tooth replacement, one being fractured teeth, and also dental implants. So we have all these issues, and I think it needs to be divided probably between pediatric OI, which is the growth and development of the dental cavities and the teeth and how jaws are forming, and also the dental care over adult population.
Great. So you mentioned Dentinogenesis Imperfecta. Do most individuals living with OI also have Dentinogenesis Imperfecta?
Yes. Well, I should maybe just expand a little bit on Dentinogenesis Imperfecta. The problem with Dentinogenesis Imperfecta, it affects the inside of the tooth, and it tends to promote fractures. The enamel, which is the outer portion of the tooth, is usually not affected. So when you have Dentinogenesis Imperfecta, you will have tooth discoloration, more tooth fracture. It's much more difficult to restore these teeth or to put fillings in these teeth, and many times you have to put crowns over the teeth, and hopefully, depending on the severity of the Dentinogenesis Imperfecta, hope that the tooth is not going to fracture. So it's a lifelong issue that we have to deal with, and as of now, we still do not have a very successful treatment option in severe cases. In simple, moderate dentinogenesis imperfecta, I think we are now doing pretty well. To answer your question, Petra, the incidence varies with type. As an example, the type 1 OI patients, where the less severe form of OI, have about 20% incidence of dentinogenesis imperfecta. The type 4 patients present about 40 to 50%, and the type 3s, which are the most severe types, have about 66, so two-thirds of patients with type 3 OI will have DI. The rarer forms, the type 5s, 6, and 7s, usually do not present with DI. Some interesting points, the primary dentition is usually more affected. So the children will present with their baby teeth much more affected with DI, which many times require to have these teeth capped with stainless steel crowns at a young age. And something that we have kind of not discovered but observed while during your observation by the BBDC is the severity will vary by type, but it varies also within the same patient. Some teeth seem to be much more affected than others. An example being the big first molars that erupt at 7 to 8 years of age seem to be more affected than other teeth.
Interesting. That's really informative. So how would a dentist or an orthodontist distinguish between what you would call significant dental issues and dentinogenesis imperfecta? Is there a test that can be done, or is it just observation?
Well, right now that's why we have this BBDC consortium. It has always been reported as a generality. We have DI or you don't. Our observations seem to point towards more individualized treatment in the sense that patients will present very severe DI. They will wear down the dentition very quickly. They will have breakage of the enamel surface. They will have significant dental pain, unfortunately, and the teeth will end up fracturing and being lost. That for the most severe part, the most severe group, sorry. For the less severe patients, we can definitely do some treatments. The most common ones being done on young patients is to, again, as I said, to place restorations, which are crowns over the teeth, totally over the teeth, because the DI teeth do not respond very well when you do a filling, like the regular fillings we do on patients. When you start removing the part that is too soft of the tooth, by just placing the filling, you will actually make the tooth even weaker. So we are now looking at putting crowns over the teeth on kids. Unfortunately for adults, it's the same indication, but the costs are much higher because you have to put porcelain crowns and they are pretty expensive. So the treatment for DI is actually either observations of the teeth where they're not too involved. You can also put veneers, which are kind of facings to hide the color on some of these teeth when they are solid enough. And again, it's an individualized treatment option. And if the teeth some of the teeth on some patients are too damaged, I think the best thing to do is to invest more time and energy on the teeth that are less involved in the DI process and save the teeth that have a much longer prognosis, and then maybe, and we'll talk about that, maybe consider dental implants for the ones that are really not salvageable.
Okay. So how long do crowns and veneers typically last for someone who has OI? Do people usually have to get them redone or maintained?
Yes, in the general population, we say that, and it evolves all the time because dental materials do get better over time, and we are now in very, I would say, very efficient restoration materials, but we tend to think that crowns have a lifespan of about 15 to 20 years in an affected population. On DI patients, it's very much more difficult to make a prognosis because the tooth will continue deteriorating from the inside because the dentin is inside the tooth throughout the lifetime of the patient. The only difference from patient to patient is how quickly this will occur.
Okay. Thank you. That's very interesting. You mentioned earlier that malocclusion is a common dental issue for people who have OI. Could you explain a little bit more what malocclusion is?
Yes, well, malocclusion is actually affecting pretty much a majority of the population and affected or not by OI. Well, what it is really, it's a malalignment of the teeth or the jaws. So you either have your teeth are misaligned, what the most common malocclusion being a crooked teeth, as people say, my teeth are crooked, or they have an overbite, which is a difference in alignment between the upper and the lower jaws. So it can affect either the teeth, the jaws, or both. Usually what you also have in normal population, or the unaffected population, I should say, is the most common malocclusion is crooked teeth, followed by the lower jaw being set back, which people tend to call an overbite. So people present with a lower jaw that is too small, and the upper jaw is fairly normal. In the OI population, our most common malocclusion is actually the upper jaw being set back and too small, which is a much more difficult malocclusion to assess and address. So pretty much I would say that in the general population, this malocclusion, where the upper jaw is smaller and set back, is about affecting 2 to 3% of the the population. It's more common in Japan, by the way, but that's a bit irrelevant. But in the OI population, it affects up to 66 to 70% of our OI type 3 patients. So it becomes a very specific malocclusion. On top of this, due to the fact that the upper jaw does not develop at its full potential, what you end up having is called lateral open bites, which is a very specific issue that we found on the OI population, which means that the back teeth, the upper and the lower back teeth, do not meet at all. There is a big gap between the upper jaw and the lower jaw in the back part of the mouth, which does not allow our OI patients to eat and function properly. So that's a very specific malocclusion. So we can say that OI patients present very specific malocclusions that are actually not found in the unaffected population, which makes the orthodontist and dentist a little bit at a loss to treat our patients, because they don't quite know how to approach the problem, because they don't deal with these problems very often. So that's why in Montreal we give quite a lot of advice to a lot of orthodontists who accept to treat our patients by giving them a different approach. So what I'm saying is the malocclusion is present, but it's vastly different from the norm, I would say, and it requires some very specific and very pointy approach that is not usually what we do in our regular day of work. So OI patients do present some specific challenges at the I would say tooth alignment or jaw alignment problems. At the same time, also the most severe patients, which are the type 3 patients, do present the most severe malocclusions and would benefit in many cases from it's called orthognathic surgery, where you do an surgical operation to get the upper jaw to align better with the lower. But unfortunately, many of these patients are not candidates for this type of surgery. So we still are in the discovery stages, I think, on how to approach the malocclusions presented by the most severe OI patients. I think we're getting pretty successful for the Osteogenesis Imperfecta type 1 patients, who present the same type of malocclusions but much less severe. And with a bit of guidance, I think we hope to get better results in the near future.
Okay. So people who are living with more severe types of OI, why would you say that they aren't the best candidates for orthodontic surgery?
Well, for different reasons. Again, even an unaffected population, there is an amount of bone that you can stimulate. When we move teeth in orthodontics, what happens is we tend to move the bone with it. It's called the dental alveolar bone, which is the housing where the teeth are. And this bone is very responsive to tension. That's why you put braces on patients and you pull on teeth and you push on teeth. But you have a limit to how much bone will be created. On the most severe patients, the extent of the malocclusion is pretty severe, and the amount of bone you can hope to create, which first of all is decreased because of the OI condition, is actually larger than you would need to be able to correct the malocclusion. So again, we don't quite know because we don't have a lot of experience on how much we can place forces on OI teeth, which are on patients with OI on their teeth. And if they have Dentinogenesis Imperfecta, it becomes even more difficult because then you cannot really put braces on these teeth. You have to use plastic trays, or you have to use some other means of tying the orthodontic appliance. And right now we are, with the more severe cases, we are more into the the trial basis of seeing how we can improve the malocclusions. Again, the simpler cases we can do in a controlled manner, because you put less force. You have to change a little bit the therapeutic approach. But on more severe patients, they still pose a significant challenge. Plus, obviously, there are a lot of the, especially our North American patients, are on IV bisphosphonates, which again is not helping the orthodontic treatment because the bone turnover is reduced, and we need this bone turnover in order to move the dentition into a better position.
Okay, that makes a lot of sense. Thank you so much for explaining that. So you mentioned bisphosphonates and that development on the teeth. There have been a lot of recent studies on the effects of bisphosphonates on tooth development. What would you recommend to your patients or to fellow physicians who are concerned about bisphosphonates?
Well, the first thing, we did extensive studies because we're doing a lot of research right now with the BBDC. We're doing a lot of research, and we are actually the majority of the articles written on biphosphonates are related to osteoporosis, and it's oral bisphosphonates, and it's on older adult patients, usually female adult patients. Unfortunately, there is not a whole lot written on IV, which is what our OI population receives, and the population is much younger. So there is not too much written on the IV, like biphosphonate treatment, long-term therapy on the effects on jaws and development of the teeth. But I did some research, and right now what I can tell you is, first of all, IV biphosphonates will tend to delay the eruption of the dentition. So you'll get your teeth later, about 1.5 years to 1.7 years later than the non-treated patients. What else? There is also some animal studies that show that biphosphonates will tend to result in alteration in the tooth size and also in the root size, and get some differences, I would say, of morphology. So the teeth will have a slightly different morphology and will also erupt later, as I said, and be a bit more fragile. But that's to be verified. And what else can I say also? There is also this big question, obviously, is do you get osteoradionecrosis of the jaw when you use IV bisphosphonates in OI patients? It's a big deal. So again, we did a study in 2008 at the Montreal Children's Hospital, and we found no evidence of ONG, which is osteoradionecrosis of the jaw, in all our patients. We didn't have zero problems, but it was only simple extractions. So we still don't know if patients would require extensive facial surgery or dental implants, as an example, and be on IV biphosphonates, especially if they are adults or young adults, what type of risk they are going to be encountering, because the studies are not just there yet. All I could find was everyone says you should be very careful because, again, the bone in Osteogenesis Imperfecta patients is different. They take bisphosphonates, which are fairly potent drugs, and at the dental alveolar level, which is the mouth, we have no studies for IV bisphosphonates on OI patients. It doesn't mean that it doesn't exist. It's usually this ONG is usually reserved for people who are much older and who have other health issues. So that's all I could find. There was not much, and I do apologize for that.
No, that's really helpful. Thank you so much for explaining that.
Mm-hmm.
We also get a lot of questions about the success rate of dental implants in people living with OI. From your experience, what factors can affect the success of dental implants?
Well, dental implants have been invented about 30 years ago by, I think it was a Swedish Dr. Brånemark, and what he found is titanium, which is the main material of dental implants, will integrate, meaning what you do is you put a piece of titanium or titanium screw in the jaw, and the bone will actually grow onto the titanium, which is kind of unusual because, as an example, stainless steel the bone will reject it. So that was a very significant finding. So obviously when you do an implant, there is a biological process that happens where the bone is actually going to bind, it's going to stick to the titanium. So what you need for implant success is you need a bone that is fairly healthy and will give some, when you put the implant into the jaw, you will need this period of what we call remodeling or integration, where the bone is going to grow right onto the titanium. So you need bone turnover, which and you need apposition, which means making bone, and resorption, which means removing bone. So the biphosphonates actually do not promote too much of the resorption pattern. So you still need you make bone. So theoretically, on a patient with bisphosphonates, you would have good integration. The problem is now is the quality of the bone in OI patients, which is different from the unaffected population. So depending again on the severity, I would argue that if you have a patient who has an OI type 1 effect and he has less bone but normal bone, the dental implant should be no problem. Then you will have again to discuss the potential osteoradionecrosis of the jaw. So osteonecrosis of the jaw. Sorry. So right now, again, I did some studies because I had the questions, and a lot of people asked me this last summer in Orlando, can I get dental implants? And all the reports are mainly, there is no large cohorts of patients being treated with IV biphosphonates receiving dental implants. It's only on people with oral biphosphonates, and the reports were pretty positive. There was no major problem. I also found some studies that said over 50% of the implants on severe OI patients will fail, meaning 1 out of 2, which is not really an acceptable percentage. It's too much. Right now, we still are a little bit, I would say, in the dark for our most severe OI patients, type 3s and 4s, I would say. But I would argue that the type 1 patients would be a good candidate for dental implants if there is some, I would say, precautions taken, and you have to talk to your physician and see how much biphosphonates, how long the biphosphonates has been interrupted before you consider putting the implants in. The biphosphonates have a very long half-life, meaning they stay in your bones a long, long time. So I think the physician should be really consulted, and caution should be taken. I would, at the moment, be a little bit worried about doing implants on a regular basis on patients with severe OI. And something else I forgot to mention, if you want to put a dental implant that has a fairly good chance of success, what you need is bone. You need a lot of bone because the implant is fairly long, and even in unaffected population, what we do, many times, they need what we call bone grafting, when they take some part of bone and they will insert it prior to the procedure to make bone to allow for the implant to be inserted at a later date. So in OI patients, then the questions we have is this bone grafting procedure will be successful. And unfortunately, again, there are not too many studies in the literature that reports on high success rate for bone grafting prior to implant placement in OI patients. So I would be cautious.
Okay. Well, thank you so much for reviewing all of this material. It's very informative and helpful for us, and I'm sure a lot of our listeners. So thank you, Dr. Retrouvey, for taking time to talk with us today.
Well, you're most welcome, and hopefully I was informative enough, and I unfortunately do not have all the answers now, and hopefully with the research we are conducting right now, we'll have much more interesting and positive outcomes to report in the near future. Thank you very much.
So if anyone has any questions, feel free to email them to bonelink@oif.org, and we can forward them to Dr. Retrouvey. So stay tuned. We'll be back for another podcast next month. Thank you again. Bye-bye.